Rahim. Let us start our meeting tonight. I would like to welcome all the colleagues, the participants, and welcome you all. And I hope you are not get bored from the length of our course. But anyhow, it is very beneficial for us first and for all of you. And on behalf of the participants, I would like to welcome Professor Walid. Professor Walid is Assistant Professor of Cardiothoracic Surgery at Al-Azhar University, and currently he is a consultant cardiothoracic and transplantation surgery in Ireland. I would like to welcome Dr. Adil Riyami again and again, and Abdul Masood Mansour, and I myself. Our program today will be a lecture from the other phase of PCI. We will discuss coronary artery dissection, and Dr. Mansour will go to discuss aortic root and ascending aorta anatomy and tics and tricks in radial course. First of all, today we are going to discuss coronary artery dissection. Before we discuss the subject, I would like to present this case. She is a 56 years old lady. She had undergone right coronary artery PCI 3 years ago for unstable angina. She was not infarcted. She is non-insulin dependent diabetes mellitus. She came complaining of recurrent chest pain with non-specific ECG changes, and enzymes are normal every time. The pain was not clearly related to effort, so I was not convinced that this is ischemic pain. Echocardiography does not show any regional wall motion abnormalities, and the left ventricular ejection fraction was normal. I asked her to get multi-slide CT scan first before going to coronary angiography because I was not convinced very much with the pain. Multi-slide showed that there is a mild atheroma in the proximal LAD that is not causing significant obstruction. At a day, she phoned me, I'm going to the hospital because I am getting chest pain. And this is a pattern of complaint I had 3 years ago, and they were denying that I am having a coronary artery disease, as exercise was negative, echo was normal, everything was normal, and when they performed coronary angiography, it showed that I have a right coronary artery lesion, and they put a stent. So the same scenario is being repeated again. I'm going to the hospital now, and please, I need to undergo coronary angiography. She went to the hospital, and next day we performed coronary angiography. This is the left system. As you can see now, the short, ultra short left main, small circumflex vessel, and long LAD that trifurcates into 3 branches. This is a cranial view. You can see now. This is a left system. Look at it well. I couldn't see any tight lesion in the left system. And this is the third spider or LAO caudal view. And this is the anatomy. This is the left system. Are you happy with the left system, Mansour?
I couldn't appreciate. I couldn't appreciate any major issue. Apart from tortuosity of the LAD, significant tortuosity.
Okay. Is there a lesion to explain chest pain, Abdul Masood?
Actually, from the, as you mentioned, Dr. Sameh, it's a very short left main, and the LAD may be at distal segment. There is some sort of intramyocardial bridge, distally, and so it's maybe for the meantime this is the cause of chest pain.
Adil,
So there
should
is,
we move to RCA?
Looking at the angio that you showed, I would move to the RCA.
Okay. Actually, this was a decision of all the people in the cath lab. Let us have a look on the stent of the RCA. But I asked, I don't know why, I asked the radiographer to get lateral view to show the left system again to document that it is still healthy in all views, and this is the lateral view. What is the diagnosis and what to
actually,
do?
if you allow me, Dr. Sameh, to give a comment
Okay.
here,
Go ahead.
the catheter, yeah, the catheter, it's selectively cannulating the left main, sorry, the LED, and the tip of the catheter hitting the roof of the LED, and in the lateral view, I can appreciate there is staining and complete occlusion in the LED. So this staining, most probably it's related to dissection. Yes, this is staining. So this is staining in the proximal LED, and most probably this is the section starting in the proximal LED, and most probably it is related to the tip of the catheter.
Okay. Actually, in lateral view, I couldn't see the LED. And it's not a selective injection because the catheter was there. If you look at the previous ones, you will see that it was deeply engaged. Actually, in the LED, it was engaged, so there is no selection at all, and it was a very short left main. So this is a dissection
Yes.
of the LED and the staining. I shifted immediately to guiding catheter, and you can appreciate now that there is a dissection of the left main, sorry, of the LED here, just distal to the origin of the circ, and there is impaired flow in the other branches. This is a guiding catheter. We got the guide wires and inserted the guide wires. By the time I inserted the guide wires, there was no flow in the three major branches of the LED. I inflated the balloon in the area which I suspected the dissection to be in. There is a little bit some flow now, you can see, but there is a hematoma forming here and starts again occlusion of the LED. But anyhow, we have a flow in the three major branches of the LED. Immediately, I put the stent and inflated the stent. And you can see now the three branches have regained again, and we return it to the baseline angio. So it was a dissection of the LED by the diagnostic catheter, and it was successfully treated with stenting. Okay, I can see now this is a diagnostic, and this is a diagnostic in caudal view, and this is after correction. All the branches and all the small and large branches are regained again, and this is again diagnostic catheter in LAO caudal, and this is a PCI LAA caudal. So we return it back to baseline with the stent. So it is dissection of the LED with the diagnostic cardiac diagnostic catheter. It hits the roof, and this was the atheroma that was reported in the multi-slice, and they said that it is not causing significant obstruction. No significant narrowing of this segment was documented again by angio, but it was a vulnerable plaque. Once the catheter hits it, it ruptures, the plaque ruptures, and dissection occurs. We did not forget the RCA. The stent in the RCA is patent, and it's a large dominant vessel. This is an example, another example from the literature. Diagnostic catheter in the left system. The LED has gone here because the dissection of the LED at its ostium, where the diagonal could be seen. So this is a diagonal, and this is a circle obtuse marginal, and this is a place where the LED should be. It will show right now a dissection occurred. Okay, this should be the course of the LED, which was totally occluded by a dissection flap. The wires were placed in all the three vessels, diagonal, circumflex, and the LED, and you can see it now. The wires in the LED, which is totally occluded here. The vessel was stented, and you could see the LED has come again here. So it was a dissection of the LED by the diagnostic catheter, and it was properly treated. This one from the literature. The agenda of today, discussing the dissection. What are the causes? What are the risk factors? What types of dissection? How would we diagnose? What is the prognosis? How would you treat? And the conclusion. Coronary artery dissection may be spontaneous dissection of the coronary vessels. It may be the result of blunt trauma to the chest, and it may be iatrogenic induced during coronary angio and PCI. Iatrogenic dissection during PCA may be aorto-ostial, the proximal body, proximal part of the main vessels, that extends retrogradely to involve the coronary sinus and the aortic root, and it may extend distally the body of the vessel and extend this distally. It may be caused by the wire, by a balloon, by a catheter, diagnostic or guiding, or by any equipment used during PCI. If it extends retrogradely, it involves the proximal segments. If it is in the ostia of the blood vessel, it will involve the aorto-ostial. If it is, spreads or extends antigradally, it involves the main branches of the target vessel. Before discussing the pathology of dissection, let us remember first, what are we actually doing during the routine PTCA and stenting? What we are actually doing, and we are intentionally inducing reasonable controlled injury for a therapeutic purpose. So what we are usually doing during our PCI is inducing reasonable controlled injury for a therapeutic purpose. What is meant by reasonable injury? Reasonable injury, we are inducing during our PCA daily work with PTCA is intimal fracture, intimal splitting, stretching and localized dissection of the medial muscle fibers, irreversible stretch of the adventitia. So the three layers, intima, media, and adventitia of the blood vessel wall are injured during PTCA. Here again, once you inflated the balloon in this lesion, there is affection of all the three layers of the blood vessel with our routine PTCA with the balloon. If this reasonable controlled injury becomes uncontrolled, this will result in complications. So in terms of dissection, what is meant by uncontrolled? In dissection, intimal tear occurs. The blood flows from the lumen of the blood vessel through the hole in the adventitia of the intima and spreads in the splitting the medial muscle fibers and causes a false lumen. So the true lumen is here. Once dissection occurs in this area, the blood flows in the true lumen, and behind the intimal tear, it causes false lumen here. The false lumen will cause blood and will hematoma, and the hematoma will totally occlude the artery. You can see it here. That this is the normal flow. When tear occurs in the intima, the blood flows antegrade through the true lumen and behind the intima into a false lumen. A false lumen occurs and the blood accumulates. Then thrombus occurs in the false lumen and occluded the main vessel here, and the entire vessel is occluded. This is the dissection. It is not a perforation, because in perforation, which we discussed the last week, the three layers, the whole three layers of the blood vessel wall, intima, media, and adventitia are injured, and the lumen of the blood vessel wall reaches outside. The blood gushes outside in perforation into a pericardial space and causes tamponade or a chamber or intramyocardial. But in dissection, there is a still the false lumen is separated from outside by most of the media and the adventitia of the blood vessel. So they are totally different. Perforation is exaggeration of dissection. Dissection is a smaller one step in the perforation pathology. This is a dissection of the right coronary artery, spiral dissection induced by diagnostic catheterization. And this is again dissection of the left main coronary artery here and there by the diagnostic coronary cardiac catheterization. Coronary artery dissection is angiographically defined as visible intraluminal filling defect or extraluminal opacity or flap complicating the dilatation site. This is the angiographic definition of dissection. During our routine daily PTCA, it occurs in angiographically seen in up to half of the patients during PTCA. If we use IVUS, 80% of the PTCA sites will be subjected to some sort of dissection. So this very small area of dissection, which could be seen very clearly by IVUS, will not show an angiography. So IVUS is much more sensitive in detecting minor and smaller areas of dissection than angiography. The dissection is occlusive if it is complicated by certain complaints, and it is non-occlusive. The dissection occurs and it does not occlude the artery if no symptoms occurs, no ECG changes, and no impairment of distal flow. And this is the situation in most of the dissections we are discussing right now. Why some people develop dissection and others does not develop? What are the risk factors that makes the patient prone to develop dissection? There are lesion-specific factors, calcified lesions, eccentric and long lesions, complicated lesions, ulcerated or thrombus containing, lesions located in angulated coronary segments, totally occluded arteries are all susceptible to dissection. This is a calcified right coronary artery. Once the balloon passed and inflated, dissection occurs in the right coronary artery here. There are other factors, lesion-related factors we discussed, technical factors that makes the patient prone to develop dissection. The use of stiff-tipped or hydrophilic-tipped guide wires, angioplasty balloon overinflation, especially the compliant balloons, balloon oversizing, balloon to artery ratio more than 1.2 to 1, no coaxially or deeply engaged catheters, diagnostic or guiding, large bore catheters, and ampulus-shaped catheters. This is an example of dissection. Again, spiral dissection involves the proximal 2/3 or half of the right coronary artery and used by the diagnostic catheter. And fortunately enough, the guide wire could pass through the true lumen distally, so this vessel can be corrected. This is a LAD, tight calcified lesion here. Once the balloon is inflated here, dissection occur, and there are probably 3 lumens. This was fixed by a stent. Other factors that make the patient prone to develop dissection catheterization for acute myocardial infarction, variant anatomy of the coronary ostia necessitating extensive catheter manipulations, and I think Mansour will go to discuss this in some detail later on. Vigorous contrast media injection, vigorous deep inspiration, and during retrograde PCI. The right coronary artery is the most frequently affected vessel and by dissection, followed by the LED, followed by the left main, and the LCX is the least one to develop dissection. This example of dissection of the proximal part of the RCA, starting from the tip of the guiding catheter or of the diagnostic catheter, and it is corrected here. Actually, this dissection, which occurs paraostial, extends to involve the right coronary sinus, and you could appreciate the staining of the right coronary sinus here because of the retrograde extension of the dissection. Circumflex lesion here and calcified lesion. Once the balloon was inflated, dissection occurs in this segment. To avoid the occurrence of a major dissection or flow limiting dissection, there are certain precautions we have to take care of. Adequate coaxial engagement of catheter into the coronary artery is important. Careful catheter handling, continuous pressure monitoring in order to ensure that there is no pressure damping or ventricularization, maintaining coaxial alignment of the guiding catheter with the coronary ostium during the passage and retrieval of intervention devices, stents, conventional balloons, cutting balloons, and others. Pressure damping. If you look at this pressure in the aorta, once you selectively engage the ostium of the blood pressure, of the ostium of the coronary artery, if the pressure dampens here, so you have to avoid injection. You have to withdraw your catheter from this situation of damping occurs, because damping means that there is a significant spasm at the tip of the catheter, or the catheter is hitting the wall of the blood vessel. Any injection of dye while the pressure is damping, this will result in dissection immediately. So you have to avoid injecting while damping or ventricularization occur, and just withdraw your catheters and check where you are. There are 6 types of dissection. A and B are minor dissection that have not been shown to increase morbidity and mortality. They are treated conservatively and they are self-limiting. They are characterized by dissection that shows angiographically, but there is no persistent of contrast staining at the end of the injection. While major dissections from type C to F, extraluminal cap or spiral dissection, or persistent interluminal filling, or total occlusion of the vessel, and all are associated with persistent contrast staining after the injection, and the dye is cleared from the blood vessel. This is a explanation, and this is a draw. This is one type E dissection of the LED with filling defect here and thrombus formation. And this is example of type D dissection, which is a spiral dissection, taking probably the middle 2/3 of the left anterior descending artery. And this is type F, which is associated with thrombus formation and total occlusion of the LED that could be treated and opened here again. And this is dissection which occurs at the ostium of the right coronary artery. It extends retrogradely into the right coronary sinus and the aortic wall. Staining of the dye in the right aortic root wall persists here, but once stenting the ostia and sealing the dissection site, the clearance of the dye was noticed after stenting and sealing of the dissected segment, and the dye which was retained or staining the aortic root here is no more seen once you dissect it. Major dissections usually predisposes to acute occlusion and ischemic complications. Minor dissections are generally tolerated, self-limited, treated conservatively with no complications. The need for emergency CABG particularly disappeared in the era of stent formation, the stent use, but actually the need for emergency CABG was the situation or the regular situation at the era of balloon dilatation BCA before the advent of coronary stents. Major dissections may cause in-hospital acute vessel closure in 1/3 of the cases, need for emergency CABG, myocardial infarction, and repeated angioplasty, these 4 major dissection. The type of dissection which we should be concerned nowadays and we should be carefully looking at is the edge dissection after stenting, which may be predisposed to stent thrombosis and occlusion. If you look at the proximal edge and the distal edge of the stent, the distal edge of the stent may cause dissection in this area, so we have to be very careful in observing the distal edge of the stent, as dissection at the edge of the stent is frequently occurring and might precipitate to thrombus formation. You can see a tight lesion here in the obtuse marginal branch. Once the stent was placed, distal edge dissection or distal end dissection occurs here, and the OM branch was totally occluded. And in this very badly diseased LAD, once the stent was placed, there is a proximal edge dissection here occurs, can be noticed. If this left untreated, it may cause thrombus formation and the total occlusion of the dilated vessel. Treatment of dissections, conservative if no symptoms, no ECG changes, hemodynamic the patient is stable, persistent TIMI3 flow in the lesion and the vessel which is shows the dissection. To stent or not to stent, it depends on the size of the vessel. Usually vessels less than 2 millimeter, we can treat it by repeated balloon angioplasty at low pressure for a longer time, but larger vessels should be stented at the dissection. We will move to left main artery dissection because the patient we have, if she don't have a long, ultra short left main, the dissection could have happened in the left main artery. Inadvertent manipulation of the diagnostic or the guiding catheters these are the precipitating factors. Balloon dilatation near the left main coronary artery bifurcation or at the ostium of the LAD, deep intubation of the guiding catheter, especially during a balloon or catheter or balloon or stent advancement or retrieval, may precipitate to left main dissection. If the dissection in the left main is confined to the body of the left main, it is type 1. If it extends antegrately to involve the LAD or the circumflex, it's type 2. If it extends retrogradely to involve the aortic root, it is type 3. This is example of type 1 dissection confined to the left main coronary artery that was treated successfully by stenting. And this is dissection of the left main that the circumflex was double lumen on both arteries, and this is dissection of the left main that extends retrogradely to involve the left coronary sinus. Aortic root dissection is rare, but it's mainly a sequelae of coronary artery dissection extending from the ostia of either the right or left coronary sinus to involve the aortic root. The right aortic sinus involved in more than 50% of the cases. It is most often related to deep coronary catheter engagement and the dissection of the ostia. This is an example of ostial dissection of the coronary artery that extends to involve the right coronary sinus and the proximal part of the aortic root. Here, again, dissection of the right coronary artery that retrogradely extends to the right coronary sinus and probably the proximal part of the aortic root, and it's sealed here once the ostium of the right coronary artery was stented. In this patient, the dissection in the ostium of the right coronary artery extends mainly retrogradely and involves the right coronary sinus and the aortic root. After stenting, still there is a dye in the aortic root, and this is again dissection with retention of the dye in the aortic root and the ostium of the right coronary sinus. This was iatrogenic induced coronary artery dissection, but dissection may occur spontaneously without any intervention, and it may involve single or multiple coronary arteries. It is mostly seen in pregnant ladies and in connective tissue disorders, Marfan's, Kawasaki, and cocaine abuse. It is divided into 3 types, and we will talk about spontaneous dissection later on. This is a spontaneous dissection in the LAD, and this is a spontaneous dissection again here, and treated by stenting here. In conclusion, iatrogenic coronary artery dissection is a common complication of invasive coronary procedures. Most of the dissections are minor and self-limiting and treated conservatively. However, major dissections, if untreated immediately, may lead to life-threatening complications. In case of large vessel dissection, every effort should be performed to keep the PTCA wire securely placed distally in the true lumen of the dissected vessel. Iatrogenic left main coronary artery dissection is mostly catheter-induced. That's why the need for proper selection and the meticulous handling of the coronary catheters, adequate coaxial engagement during every minute of the procedure, gradual ramping of contrast media injection, the absence of pressure, especially in the absence of pressure damping or ventricularization. Currently, bailout PCI for iatrogenic coronary artery dissection appears to be safe and feasible with acceptable short and long-term outcomes. Stent edge dissection should be carefully looked at as it predisposes to stent thrombosis. CABG is a valid treatment strategy in patients who are hemodynamically stable and who otherwise would have been deemed surgical candidates on the basis of extensive multivessel coronary artery disease. Thank you.